Move on to the next speaker, Dr. Shashwat Jani.
Wish you all a happy Doctor's Day. My topic is transfer of a critically ill mother. I bring greetings from the beautiful Ahmedabad city. By title, you can imagine a very sophisticated ambulance and high-tech ambulance with all the facilities. Yes, we need this for the transfer of a critically ill mother. At least this. If not possible, then at least this. But out of 100 women in India or in South Asian countries, only 30 to 35%, 30 to 35 women get this transport service. Otherwise, in the tribal area, can you imagine that? They are carrying their pregnant women to the hospital. You can see this there. On the court. These are all the tribal areas or northeast countries, northeast states. Husband carrying her wife on his wife on shoulder. This is the transport facilities in the tribal area or the villages. See, this is horrible situation, and this becomes the news. This is a handmade stretcher, and they are carrying the woman up to 10 to 16 kilometers. Even doctor has to carry the patient, and this is our Gujarat. Okay, there is delay in transfer. In setting where maternal mortality is highest, three crucial delays are directly associated with the elevated rates of maternal mortality. These are delay in seeking the health care, delay in reaching the health facility, and delay in obtaining appropriate care upon reaching the health facility. And to improve this obstetric outcome, a woman must recognize that she is in the she needs obstetric treatment immediately. Her family should support. In India, most of the families don't support the pregnant woman. They came into the last moment. So family support is must. Able to assess the transportation, that is must. Successfully transported to the appropriate place and must receive the treatment in immediately. Why do pregnant women become critically ill? There are a wide range of conditions, and they are mainly divided into 4 groups. The first is the specific to pregnancy, that is preeclampsia, acute fatty liver of pregnancy, eclampsia, obstetric hemorrhage, amniotic fluid embolism, and peripartum cardiomyopathy. Second, increased susceptibility in pregnancy, that is venous thromboembolism, aspiration syndrome. Third, underlying medical condition that is exacerbated by the pregnancy, and that is congenital heart disease, pulmonary hypertension, and chronic renal failure. And fourth, unrelated to pregnancy and coincidentally developed during the pregnancy. These are diabetic ketoacidosis, pneumonia, and asthma. Now, let us see what are the types of transfer. First is the intra-hospital transfer. That is transport of a patient from one location to the another within the hospital premises. Means from the pre-labor room to labor room or labor room to ICU or a radiology department. Second, inter-hospital, transport of a patient between 2 hospitals, from primary health center to higher tertiary, secondary or tertiary care center. And third is the scene run. That is transport of a patient from a non-medical side. That is, if patient has an obstetric emergency on the road or outside the hospital, and then if she needs to be transported. That is scene run. Transfer of any sick patient, either within the hospital or between the hospitals, is potentially hazardous, if not if proper care is not taken. Therefore, careful multidisciplinary coordination to ensure the necessary resources essential to reduce the hazards. What are the different indications? These are critically ill, which patients transfer. Critically ill, antenatal or postnatal require transfer to the tertiary care hospital. In utero transfer from PSC to the another hospital or higher center, home birth transfer from home to hospital, postnatal transfer of mother to another hospital for advanced care, postnatal transfer of mother to X-ray department for embolization, transfer of mother to ICU or another ward within the hospital, either antenatal or postnatal, neonatal transfer, and transfer of woman in labor from pre-labor room to the labor room. So critically ill obstetric patients are at increased risk of morbidity and mortality during this transport, and risk can be minimized and outcomes improve with the careful planning and communication, appropriately qualified personnel, availability of appropriate equipment and the drugs, and monitoring. That is must. First is the pre-transport communication. When an alternate team at receiving location will assume a responsibility for the patient after arrival, continuing of patient care will be assured by physician to physician and nurse to nurse, and communication to review the patient condition and the treatment plan. But before transport, pre-transport stabilization, that is more important. Ensure the patient is stabilized as best as you can before the transporting the patient to the another hospital, because hasty transfer of an unstable patient may cause more harm. These are different, what are the modes of transport? Before deciding the best mode for transportation, this following needs to be considered. That is urgency of transport. Whether we all know the difference between the urgency and the emergency. If this is the night time and we can transfer the patient in the morning, then always daytime transfer is always better. Depends on the condition of the patient, availability of the ambulance or other mode of transport, distance and estimated transit time and time of day, and weather. Road transport, distance from the referring center to the tertiary hospital, condition of the road, that is more important if a patient is transported from the village area, availability of transport, ambulance or four-wheel drive vehicle for the hilly areas, weather, that is more important, air transport, that is available in the metro city, depends on the severity of the cases, availability of the helicopter and weather also. These are small things which require, which are very helpful in the decision of the transport. That is, local knowledge is essential. Medical officer or paramedical staff, those who are posted in the remote clinics or PSC, should learn about the area where they are serving and find ways of quickly and safely transporting their patients. Accompanying personnel. It is strongly recommended that a critical care mother should be accompanied by one senior and one junior obstetrician. If not possible, at least one obstetrician, junior obstetrician may be there. One critical care specialist or intensive anesthetist, and one trained nurse. Apart from critical care specialist, obstetrician and nurse should be trained in ACLS, advanced cardiac life support and basic life support. Now accompanying equipments and drugs. There is a BP monitor, pulse oximeter, defibrillator should accompany every patient without exception. And this is a very good, if possible, memory capable monitor should be there, so that the data can be reviewed after shifting the patient to the tertiary care hospital. Equipment for the airway management of all size and oxygen with the 30-minute reserve advance should be there. Nasogastric tube should be inserted before to avoid the aspiration during the transport. Basic resuscitation drugs include adrenaline, noradrenaline, and antiarrhythmic agents should be there. Nowadays, most of the ambulances have small crash cart. They have all the emergency drugs there. But ensure the ambulance or transport have the required resuscitative equipments that is in the good working order, and including the oxygen tank. And remember that the staff should be trained. The staff escorting the patient knows how to operate the resuscitative equipments. Otherwise, they don't know how to operate defibrillator or how to connect the oxygen tube. Ensure the appropriate medications apart from emergency drugs for our obstetric patients, like Maxelf, oxytocin, parenteral antihypertensive therapy, sedative muscle relaxants, and even balloon tamponade should be there. Cross-match blood products to bring along if indicated. And these 4 emergency kits should be there. That is eclampsia kit, PPH kit, vaginal delivery kit, and neonatal resuscitation kit. These 4 kits should be there in the ambulance. Now, most important is the monitoring during the transport. All critically ill patients undergoing transport receive the same level of basic physiological monitoring during transport as they had in the ICU. And this includes a minimum and continuous ECG monitoring, pulse oximetry, blood pressure monitoring, pulse rate, and respiratory rate. These 5 parameters should be monitored during the transport. In addition, if a facility is available, capnography, continuous intra-arterial blood pressure monitoring, and pulmonary arterial pressure should be monitored. Remember, fetal monitoring should be done when we are transferring the antenatal patient. What are the adverse effects of the transport? Adverse events during the transport of critical ill patients fall into 2 general categories. One is mishaps related to the intensive care. Means when ambulance is traveling, through the hilly areas or bad roads, then disconnection of the lead, loss of battery power, loss of IVSS, accidental extubation, occlusion of the endotracheal tube, or exhaustion of the O2 supply may be there. And physiological deterioration that is related to critical illness because of hypotension or hypoxemia. Now, most important is the handing over. This should be done systematically throughout all the levels, means doctors, nurse, everywhere. Escorting MO should inform referral center MO or specialist doctor. Escorting staff nurse should inform referral center staff nurse. And proper communication and documentation is very, very important. Regarding documentation, the clinical record should have the following documentation: patient's clinical status before, during, and after transport, relevant medical conditions, therapy given, what treatment patient has received, and any other events or conditions that should be informed to the higher center. A copy of this record should be provided to the receiving facility. This is the transfer slip module. And regarding responsibility, transport team responsibility for stabilization phase is quick assessment of the patient status, stabilization of patient for transport, anticipation of problems like encountered on transport, secure all lines and tubes, and communication with the receiving physician or nurse. Thank you very much.